Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen with the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'm your host for this season's premiere episode. Tonight we're talking about heart problems, and we'll be glad to take your questions about the diagnosis, treatment, and prevention of heart attacks, heart disease, and heart failure. Please call with your questions and we'll do our best to answer them for you. The telephone numbers can be found at the bottom of your screen. I'm pleased to welcome this evening's guests. Dr. Jeff Adams is an emergency room physician with Essentia Health, St. Mary's Medical Center in Duluth, and a faculty member at the Department of Family Medicine and Community Health at the Medical School in Duluth. Dr. Mary Boylan is a cardiothoracic surgeon with St. Luke's Cardiothoracic Surgery Associates in Duluth, and Dr. Scott Mikesell, a cardiologist with St. Luke's Cardiology Associates in Duluth. Tonight we have medical students answering the phones for us. They are Tyron Rasheen of Albany, Oregon, Ben Doomer from Cambridge, Minnesota, and Cammie Young from Vernon Center, Minnesota. And I welcome you to tonight's program on heart problems. This is approximately our 33rd year of putting on this program, and we really do appreciate the continued viewership that you have provided for us. You'll also notice tonight, as you look around, that we have a lot of gadgets on our table to talk about and some very interesting topics. I'm going to start out with just some background and ask Dr. Adams if he'd talk to us a little bit about what a heart attack is.
Well, when you talk about heart attack, we usually call it myocardial infarction. It's the same thing. Basically, your heart is being stressed, and the amount of oxygen you're getting is not adequate to perfuse the tissue. And when that happens, your heart gets unhappy and expresses itself by causing usually pain. It doesn't have to. Your body doesn't have a lot of nerves down there. So sometimes when you have a heart attack, you can present with nausea, you can be short of breath, you can even have a fainting spell. Those will all be signs of having a heart attack. If you're young of age, if you're old, if you're female, they tend to present more atypically. The classic description of the guy clutching his chest and saying where to die is nice to have as an ER physician because it's pretty easy to make that diagnosis. But it's much more difficult in someone that's lightheaded or dizzy and had a fainting spell possibly or just nauseated. But in all cases, the ultimate problem is that the heart has a mismatch of how much oxygen it needs and how much oxygen is being supplied to it. That can be due to, and usually dealt with these guys by dealing with the arteries to the heart, and they're narrowed and they need to be dilated to improve perfusion. But it can be caused by other things such as anemia or other issues too, where you don't get enough oxygen to the heart.
One of the really interesting things is as an ER physician, you really deal with this, front line, front and center. And for us, I mean, it's such a great topic because heart disease is so common. And heart disease, most common #1 cause of death for men and women in this country. And I always kind of like to point out that more women than men die of heart disease every year in this country. And as a surgeon, I see those people after you've managed them, got them into the system, and it really can be a challenge when we go back and look at a patient who presents with such mild symptoms. And then Dr. Mikesell does an angiogram and they have severe disease. It's really very impressive.
Dr. Mikesell, as long as we're going down this line, we should probably talk just briefly about prevention too, as far as heart attacks are concerned, and make sure that we put that out. So would you address that issue just a little bit for us?
Yeah, prevention is one of the most common things that I get asked in my office. In fact, I have a number of patients that come in just for that sort of discussion. Most people understand, what the best methods are to prevent things that they shouldn't be doing. High salt diets, high fat diets, eating fast food regularly, things like that. And it's just a matter of, really getting into their heads and making a lifestyle change such that they're going to do that. So, that's the big dietary component. The one thing that Americans that we all struggle with is the regular exercise and trying to get out and get 30 minutes of exercise every day. The interesting thing is if you look at the studies that talk about exercise in particular, what you really need to do is go out and have 30 to 45 minutes of walking time, dedicated walking time every day. And what we tend to do is we overdo it. We overstress ourselves. We do too much too fast. we try to run and we try, and that the first time we go out there and run 3-4 miles, and then we hurt ourselves because, well, we didn't run 3-4 miles yesterday. And so it becomes this challenge and vicious cycle when actually, you know, all you need to do is go out and walk 5-6 times a week for that dedicated time. The other thing that I hear regularly, and it just doesn't work this way, is I'm active at my job. That's a good thing. I mean, you know, we have no problem with people being active at their job. We encourage that. It's better than sitting at a desk sometimes like we do all day. However, that doesn't count. The heart doesn't like that. The heart wants that dedicated time of exercise and walking, and it's good. You know, there's so many benefits to doing that.
Then there's other preventive issues too. We have to touch on smoking.
Yeah.
Mary, you've been in the chest of a lot of people.
Right.
What does smoking do?
Well, I'll preface it by saying that when we think about medicine, we never say always and we never say never, except in this one case where we can say smoking is always bad and one should never smoke. So smoking is the #1 cause of preventable illness in our country, and you know, we've known that 50 years. And it's a challenge to really help people avoid smoking, or really to get them to quit smoking. And when we think of smoking, you know, the first thing everyone thinks about is, oh, lung cancer. Well, lung cancer does happen, but smoking affects more than just lungs. It's clearly the substances that are inhaled in smoke or ingested are almost direct toxins and poisons to the blood vessels on the heart arteries. So smoking has many effects. Everyone thinks about lung cancer, but it causes severe lung disease, directly damaging to the heart, and really impedes someone from being able to get out and exercise. So it hits a lot of different parts of our health. So never smoke.
That's right. Jeff, questions are kind of coming in on how can you tell, the question that we lead off on is, how can you tell the difference between a heart attack and heartburn? And maybe if the three of you, or if you want to go into that, what should a person do? When should a person come and see you or their family doc?
It's an interesting question. You can't on some level. The average person classically does have crushing chest pain. It's different than heartburn, where you just had a meal that's pizza and you get this burning sensation. You take an antacid and it goes away. But I can count on many hands the number of times that people presented with heartburn and have a heart attack, or having a heart attack. So I don't want to scare the entire public to rush into their doctor if they have heartburn. If they've had something that's been that way for years and they eat and they get this discomfort in their chest and then they take some antacid and it goes away, it's not related to going up steps and walking, it's unlikely to be heart disease. Does that mean you shouldn't talk to your doctor? No. It doesn't mean you have to see him tomorrow. If things are different, if things are worse over the last week or suddenly getting worse, or you're waking up at night with it, or things have changed, then you probably shouldn't go directly to the ER or see your doctor tomorrow. But if something's been stable for a while, I think you have time, but I don't think you should just write it off as heartburn.
So I think that that very strongly supports our primary care providers, because if someone has a family history, has risk factors, then it still is a dilemma to figure out, is this heartburn or is this a heart attack? And the big risk factors for heart disease that we all know about are things like genetics. So if everyone in your family's heart problems, then that's one, and cholesterol and diabetes, high blood pressure. And those are kind of the things we can't control, but things we can control are smoking and physical activity, as Dr. Mikesell was discussing.
Can you predict by early death in the family, can you predict it? So that one of the questions is, my 51-year-old father died suddenly of a heart attack. I'm 43. What are my chances?
That actually, unfortunately for that person, very high. It is a genetic disease. There are multiple genes that have been identified that kind of correlate with this, but simplistically, generally it's how the body handles LDL cholesterol, bad cholesterol, that kind of drives this force. And then some people, their livers and their bodies handle it differently, and then others, like this person, probably deposit it in the arteries. And anything that this person can do to minimize the risk, no smoking, eating right, exercising, probably taking statin medication with the direction of their primary caregiver, and potentially thinking about aspirin. There's big controversy about aspirin right now, about should everybody take it, or who should take it. a patient like that comes to my office, I would say probably, you know, you should take a baby aspirin on a daily basis. And so, absolutely, I mean, when we take histories, you know, we worry about men generally younger than the age of 55, women younger than the age of 65, and that's premature coronary artery disease by definition. And any sort of direct relative on the way down is at risk. And so that is a concern, absolutely.
How about the other lifestyle disease, diabetes?
Well, I mean, obviously diabetes comes in two flavors. It comes in the genetic form in type 1 and then type 2. And type 2 tends to be the predominance of what we see on a regular basis. And then he sees in the ER in various, presentations. And has to principally deal with, obesity and lack of exercise and diet. Again, we keep coming to very similar concepts, and these are all intertwined and interrelated. And a patient who didn't have diabetes, but then continues to be obese, not exercise. A lot of times we've seen them where they didn't have it, and then they subsequently develop it as a consequence, because fat tissue in particular is exceedingly poor at metabolizing glucose and uptaking glucose, via insulin, and so that just predisposes this whole mechanism for peripheral arterial disease or cerebrovascular disease or coronary artery disease, and the deposition of LDL cholesterol in these places.
One other thing I'd say about diabetes, which makes a real conundrum for an ER physician when they see a patient come in, is a lot of times when patients have diabetes, they especially won't have typical symptoms of chest pain and chest pressure, and they have what are called silent heart attacks, and that can also really be a very confounding issue. So it pays to have a primary care provider who kind of knows you and knows your constellation of risk factors, and can really kind of get you on the right path.
As a woman, what are your thoughts about aspirin for heart disease?
Well, the American Heart Association has come out with guidelines, and the biggest, one of the biggest things that the American Heart Association has said, and this is now about 10 years, 12 years in the making, is that the guidelines for women are different from the guidelines for men. And as Dr. Mikesell right now said, there's now a big controversy about aspirin. So one thing that had been a standard is that everyone should be on aspirin if you're over 45, 50, whatever. That was the old thinking. Then it got split up, and okay, women shouldn't be treated the same as men because women had a higher incidence of bleeding complications from aspirin. So the recommendations changed, and they continue to evolve. So whereas previously would have said, okay, once you hit 45, 50, 55, you should start an aspirin, we don't say that anymore, and it's individualized to the woman and her other risk factors. So I think we're appreciating that medicine isn't such a cookie cutter management, and it really needs to be individualized. Another question that always comes up with women is hormone replacement therapy and hormone topical, etc. And that continues to be a moving target, even though hormones are not recommended as a preventative measure for women at all.
Any other comments, Jeff?
Just one thing about diabetes. If you have diabetes, that's considered an equal risk factor. It's considered as if you'd had a heart attack before. And so it's even though it's not related to your heart at all, when they look at risk, you are at high risk for heart disease, just as if your uncle had a heart attack, his risk for having heart disease is increased. Your risk if you have diabetes is increased.
Yeah, interestingly, that was a relatively new development. I mean, a recommendation that we place that on an equal placeholder as smoking and
It's a red flag.
cholesterol, et cetera. In fact, I mean, to be blunt, it is the risk factor beyond smoking that we see over and over and over again.
I want to, for the rest of the program, I'm going to move a little bit over to congestive heart failure, and then I'd like to come back to valves someplace along the way. So I'll try and watch the time. Scott, I'd asked you once before to tell us what congestive heart failure is, so I'll let you launch into that.
Sure. Congestive heart failure, I mean, related to, let's take that patient that went to the ER that had a heart attack, presumably depending on how quickly we're able to get that artery open and limit the amount of damage that happens to actual muscle tissue. What we're talking about is the heart is the pump, and the bottom two chambers of the heart pump the blood either to the lungs on the right or the rest of the body on the left. And when the heart is deprived of blood, the heart starts to die from the inside out. And basically what happens is that the chamber is no longer able to pump as efficiently or in the proper order that it had previously. And so if we fast forward this and there is a certain amount of damage, this area of the heart becomes scar tissue. Well, scar tissue has no ability to contract. Scar tissue is fibrous tissue, not actual muscular tissue. And so the pump is less efficient. We measure this very simplistically by measuring the amount of blood in the chamber before a heartbeat and after a heartbeat. We divide the two and we get what's called an ejection fraction. Normal is greater than 50% for every heartbeat, the blood being ejected. Heart failure, simplistically, is basically the heart cannot eject enough blood with every heartbeat to sustain our normal daily activities. That's the most common version of heart failure, and how heart attacks and then also multi-vessel heart disease leads to that. There are many ways to treat this: medications, cardiac rehab, actual specialized pacemakers, et cetera. I mean, there's lots and lots of things. Heart failure is the #1 diagnosis that continues to bring people into the hospital over and over and over again. That's the highest readmission diagnosis that we run into, and everything that we talked about earlier puts people at risk for congestive heart failure.
So Jeff, can we prevent heart failure?
Prevent the cause. Heart failure, congestive heart failure is kind of a symptom of something else.
We didn't
And
talk
so
about hypertension, by the way, and you might want to launch into a little of that too.
Hypertension also can cause heart failure because it's a strain on the heart. If a valve blows out, it can cause heart failure. If you have a heart attack, it can cause heart failure. So heart failure, in some ways, congestive heart failure is kind of a descriptive term of what's happening to your body. Your legs get puffy, your lungs fill up with water, and that's because the pump isn't pumping well. Why it's not pumping well can be due to a lot of different things. If you deal with the cause, which is not the lungs filling up with water, you can treat that, but that's not actually the cause. The cause is something else. We need to focus on those things, like replacing a valve or fixing an artery.
Do you want to talk a little bit about valves, Dr.
Sure.
Boylan?
You're right. When I think from a surgical standpoint of the kinds of patients we see, overwhelming still the most common type of patients we see for surgery are patients who have coronary disease. But valves are the next most common things we see. And we have a model, and in the heart we have 4 valves, and in the adult, really there are only 2 valves that pretty much ever really need to be operated on, and they're the aortic valve and the mitral valve. And as you mentioned, a malfunctioning valve can cause heart failure. It can cause heart failure because a valve leaks or because the valve is a stuck valve, like a door that's stuck and doesn't open. So when we think about valves in the adult, of the 4 valves, and I'll just show our model here. So of the 4 valves, here's a little heart model. This is the right side of the heart, and this is the left. We have a valve at the bottom of this aorta, which is the aortic valve. And we have a valve inside the chamber on the left, and I think you can see it right here. That's the mitral valve. And those are the 2 valves that really get operated on in adults. Very infrequently do we have to operate on another valve on the right side over here called the mitral valve, and even less frequently, almost rarely, do we operate on a 4th valve in the heart because they just don't cause problems. So when we think about valves, it's a very exciting time for us because of the treatment for valves. Traditionally, mitral valves, which is this valve on this side, the most common cause of a mitral valve malfunctioning today is that the leaflets or the doors kind of get worn out and overstretched and floppy. So generally for mitral valves, we're able to repair them. If someone has a mitral valve that's not working because of a history of rheumatic fever, then we replace them. And patients always say, well, how big is that valve? Is it like this or is it like this? Well, I have samples of average valves. So we either replace the valve when we have to replace it with a mechanical valve, or sometimes people call it a metal valve. And this is a typical kind of metal valve, and this is the size of it. And this is a very typical metal valve, or what we call a mechanical valve. It has 2 little flappers that open and close. So that's a mechanical valve. The plus and minus, and this is just kind of summary, the plus and minus about a mechanical valve is a mechanical valve will outlast all of us. The limitation or the drawback about a mechanical valve is that a person has to be on a Coumadin or warfarin blood thinner pill forever. And I get this question many times, isn't there another medicine? And for 20, 30 years we've been saying that other medicine besides warfarin is around the corner. So that alternative is still around the corner. So warfarin or Coumadin is the standard for a mechanical valve. The other valve that we use is a so-called tissue valve, and this is a plastic model, and you can see this has 3 little struts. And a tissue valve is made now mostly today they're made from cow tissue. In the past they were always called pig valves. And the plus and minus of a tissue valve is the advantage is no blood thinner. The limitation is that it's not going to outlast all of us because it's a tissue and it will wear out over time. Pig valves, we already said, lasted about 10 years. These valves now last longer than that, 12, 14, 15, much better durability. And there are guidelines from the American Heart Association about who should get each kind of valve. So for the adults, we generally try to fix the mitral valve. And if we can't fix it, then we replace it with one of these. For the aortic valve, that's always a replace. And I'll tell you, this is why this is so exciting about valves, because right now there's new technology for replacing valves. I hate to say it as a surgeon, but without an incision.
That's right.
So I'll let Dr. Mikesell address that a little bit because it's a big hot topic nowadays.
Yeah, and actually it's a collaborative effort between cardiothoracic surgery and my field, interventional cardiology, where the technology has been developed such that we can deliver valves in the appropriate patient, the appropriate risk patient, through the femoral artery in particular, or a couple other much less used sites. And what we do is we deliver a valve very similar to the bioprosthetic, this tissue valve, via catheters and wires. The technology and the procedure is very similar to a very old-fashioned procedure that we were taught in fellowship called balloon aortic valvuloplasty, where we just take a very large balloon and we go across a very narrowed valve and we balloon it open, we stretch it open. And we take a valve that is mounted on a balloon, on a stent, much like this, and we blow it up with that balloon and then it stays in place. The target population for a patient like this is the high-risk patient, the patient that's too frail or too old, that won't necessarily survive or do well with the surgery, particularly the postoperative course. And so we've been able to extend the people who can get some sort of therapy for particularly the aortic valve is what we're talking about, particularly, that was not otherwise possible even 5 years ago. And it's a very exciting time in our field, to be able to do this. And when we do these procedures, we actually do these together. And it's a multidisciplinary and team effort to do these sorts of things. And it's fun. We are able to reach a whole new population that previously was kind of untouchable.
We have just a couple of minutes left. Some of the other things that you brought along, I see you have a pacemaker. A small pacemaker now. They used to be 10 times that size.
Right. So you can see how thin this is, very thin.
And the pacemaker takes over when the heart.
Right. The pacemaker, these are truly life-giving devices because the pacemaker has little wires that are attached to it that thread from here, the shoulder, thread into the heart, and the little wires connect up to the pacemaker. And this pacemaker is kind of like a little mini computer. It watches the heart and it gives it a little kick. It says, hey, beat. You haven't beat, 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 beat. And they're great. They're small. They're life-saving devices. They're very common. I put pacemakers in patients and they initially are shocked and think, oh my gosh, a pacemaker. And usually we can tell them, I bet you know somebody who has one, and you don't even know they have it. Very common, truly life-saving devices.
And I see you've got some stents here too.
Yeah, we actually have 2 different stents. And this one is a little bit harder to see. Focus in right here. This is actually a coronary stent, and it's mounted on a balloon. And so what I do is I'll take a catheter up to the heart and engage the artery and steer a very tiny wire through the artery. I'll use that wire as a rail and then advance this balloon catheter across it. And if you can see the stent here, it's a mesh laser cut tube. There's a balloon underneath, and when we inflate the balloon, the stent pops open. Not unlike this one, and we pull everything out, and this stent is left behind.
Thank you.
And it becomes part of somebody.
Thank you very much. I want to thank our panelists, Dr. Jeff Adams, Dr. Mary Boylan, and Dr. Scott Mikesell, as well as our medical students, Taryn Rashine, Ben Doomer, Kami Young. Please join Dr. Alan Johns next week for a program on infectious disease and immunizations, when his panelists will be Dr. Stephen Teacup, Dr. Andrew Thompson. Thank you very much for watching, and good night.